I'm going to be talking about really how one can target what you want, the mean arterial pressure, and why. These are my conflicts of interest. I'm a consultant to every known hemodynamic monitoring company, and I have several NIH grants. What is the optimal perfusion pressure? Well, it's the pressure that allows for the body to auto-regulate its blood flow. You really don't care about blood pressure. You care that tissue blood flow is adequate to meet the metabolic demands of the individual tissues, whether that be the brain, the heart, or the kidney. Importantly, if you're below that threshold, then you're going to have ischemic dysfunction. And the other term that we use to call ischemic dysfunction is shock. So the regulation of blood flow is very simple from a physiologic perspective. We have a very high input pressure. The left ventricle generates a very high pressure into the capacitance vessels in the arterial circuit, and we have a high intra-organ output resistance. And the way in which the body increases blood flow to any given organ is the organ itself dilates to increase the blood flow. And within that context, cardiac output is only important so as to maintain arterial pressure. Therefore, the rationale for the defense of arterial pressure in a patient who becomes suddenly hypotensive is it allows for the autoregulation of blood flow. I don't have to invent septic shock to lose autoregulation. All I need is hypotension, and the vessels can dilate all they want in metabolically active tissues. I won't have an increase in blood flow. In this slide, what I'm showing you is the arterial pressure profile across the cardiovascular system, starting here at the heart and going into the veins. And you can see that there's a major pressure drop at the arterioles and precapillary sphincters because this is where all the resistance is. Also, there is no measurable arterial resistance. There is no measurable arterial resistance. If there was, you couldn't measure mean arterial pressure with a radial artery catheter because the pressure would be lower than the heart. They're the same pressure. There's no resistance between those 2 points. Okay. Arterial resistance is clearly not uniformly developed. It's actually present primarily in the arterioles and the precapillary sphincters where we get to tubular flow, and Poiseuille's law defines that that's where the major pressure drop must occur. Well, in collaboration with my colleagues in the operating room at the University of Pittsburgh, we put a flow probe on the aorta of a human being and put our finger on the inferior vena cava and decreased blood flow and measured aortic flow and arterial pressure in a human being. And this was the only study that's ever done that. It took us 3 years to recruit 7 patients. You cannot believe the IRB consent form. And what we were able to show is if you looked at the stroke volume versus the arterial pulse pressure, the values were behaving as if the output pressure that it was pumping against was 20 millimeters of mercury. At this time, the CVP was merely 2. What this is we're looking at the driving pressure being significantly less than mean arterial pressure, and we refer to this as a vascular waterfall. What do I mean? Well, this is a waterfall. This is Victoria Falls, and the rate at which water falls over the falls is totally independent of how far it goes afterwards, what the CVP is. It only determines what this vascular closing pressure is and the upstream pressure. And by the way, that's me. So if we were to look at it, we would see that the pressure-flow relationship goes to a value greater than 0. The slope of the line is resistance. So if I have an increase in resistance, I need a greater increase in pressure for flow. And if I have a decrease in resistance, I need a less increase in pressure for the same increase in flow. Well, David Kramer in our laboratory looked at the instantaneous pressure-flow relationships of the gut, the kidney, and the liver and showed that they were quite different. This is important. They not only were different here, but they had different zero flow intercept points. So watch, if I simply take a given mean arterial pressure and decrease it, what I see happening is a significantly different decrease in organ blood flow dependent upon the pressure-flow relationships. The kidney is a setup for hypotension-induced ischemia. That's why sudden hypotension causes acute kidney injury. The liver can tolerate hypotension just fine. Nobody here has seen an ischemic liver dysfunctional from hypotension. When you see a liver dysfunctional, it's because the CVP is high. And that's because the liver is phenomenally resistant, because its resistance is higher. So what we clearly have then is not one waterfall, but multiple vascular waterfalls, as identified here by a picture from Iguazu in South America. So we looked at this in human beings in the ICU, in which we measured cardiac output instantaneously, and we increased arterial airway pressure with CPAP, and we got the fall in cardiac output, an increase in right atrial pressure, or as the fall in cardiac output, a decrease in arterial pressure, and this was the arterial pressure flow relationship you saw before. Here's your critical closing pressure. This is the mean systemic pressure. This difference between there is the vascular waterfall. And it's due to a whole number of vasoactive substances that are activated. And as it stands now, the organs that are the most tightly regulated are the heart, the brain, and the kidney. Moderately would be the skeletal muscle and splanchnic, and the skin has absolutely no autoregulation. It goes up and down relative to thermal control. So let us assume that we have blood flow and versus pressure, and I have a highly constricted vasculature. It will carry a line that looks like that. Now let us assume I have a highly vasodilated vasculature. It will be looking like this. This is the vasodilated one, right? Remember, decrease in pressure is very small for this great change in flow. Well, what happens in autoregulation? Well, you start up here, and then you get into this autoregulatory range. The autoregulatory range occurs because as the pressure starts to fall, the body selectively vasodilates. What do you care about? You only care about that one point. You just want to be above the autoregulatory range. As long as you're above it, the organs will take care of themselves. If you're below it, you're on pressure-dependent flow, and I call that shock. Importantly, as you can see, in a fully dilated vascular bed, there is essentially no critical closing pressure, and thus the back pressure to flow, which is the venous pressure or interstitial pressure, becomes the back pressure. An example of a fully dilated vasculature are the coronary arteries. They have no critical closing pressure because they're always exercising. So we can say that the vascular waterfall is complete. What are the back pressures? It isn't mean arterial pressure alone. It's mean arterial pressure minus the back pressure. For the brain, it's either CVP or intracranial pressure. For the heart, since it cannot perfuse during systole because the muscle is contracting, it can only perfuse during diastole. So it's the diastolic arterial pressure minus either CVP or intrathoracic pressure, whichever is higher. For the gut and the kidney, I don't know the answer. It's definitely going to either be CVP or intra-abdominal pressure, but the kidney lives in a capsule. And the capsule, when the kidney swells, can have a higher capsular pressure than CVP. And I think that one of the major things we're going to be discovering soon is that intercapsular pressure is going to be a primary determinant of renal hypoperfusion in shock states such as sepsis. For the skeletal muscle, of course, it's either interstitial pressure as the back pressure or CVP, and you all know that because if you have a compartment syndrome, you get an ischemic muscle. Okay? So for the cerebral circulation, and this we went to all the societies and asked them the answers, and this is the response from the various societies. For the neurology and critical care neurology, they are saying intraoperative, you want to keep the perfusion pressure for the brain greater than 50. We think between 50 to 70 for post-trauma, and in CPR, you want to keep it above the same amount. For the coronaries, it's 50, but during CPR, you want to have a coronary perfusion pressure of at least 25, or you're not going to be having coronary blood flow and you won't have restoration of spontaneous circulation. For the kidney, it's really funny. The higher the pressure, the greater the flow. This is the reason why the Australians like a higher mean arterial pressure for the kidneys. But we do know that the minimal value is somewhere above 70. Okay? So we can look at the autoregulatory range, and for the heart and the brain, it's a value of about 65. But if you have hypertrophy, it'll be higher. The kidney is going to be higher still, but if you have renal vascular disease, it'll be higher as well. And thus, there is no magic one mean arterial pressure you can target to ensure blood flow to all the organs are adequate. So remember I showed you the pressure-flow relationships? Well, in endotoxic shock, we showed, I think it was 40 years ago, that there's a parallel shift initially of the pressure-flow relationship with acute endotoxemia, because what you do is you lose your critical closing pressure, but your arterial resistance hasn't changed. After about 4 hours, you vasodilate as inducible nitric oxide synthetase makes all that nitric oxide-induced vasodilation. And in fact, this explains why you see a different pressure-flow relationship. With initial hypotension and septic shock, they respond to volume with an increase in pressure. But after a few hours, the same increase in volume causes cardiac output to go up, but pressure doesn't go up at all. So when we looked at this with David Kramer, this was the original data for renal superior mesenteric. We then looked at the same animals during endotoxic shock. And the good news for you is that with the loss of tone, the vessels of the vasculature become harmonized to have a similar pressure-flow relationship. Thus, this argues for the use of vasopressors to increase mean arterial pressure because you'll have the same effect. So to address this, Ronaldo Bolomo, who's one of our next speakers, and John Kellum, back when they were very young, in my laboratory, did a study in which they asked what was the relationship between pressure and flow. And we looked at the renal blood flow instantaneously, and then we gave norepinephrine to healthy dogs, and we had, for the same blood pressure, a lower flow. So I would say to you, don't give a normal person norepinephrine. It'll decrease renal blood flow. We then induced endotoxic shock and saw again a parallel shift of the curve, just like we saw. But in the setting of endotoxic shock, giving norepinephrine did not cause vasoconstriction. We had an increase in renal blood flow because there was an increase in perfusion pressure. These are the data that allow you to give norepinephrine to treat hypotension in septic shock and expect to see organ blood flow go up. So that's a good place to be on the vascular waterfall. What should that value be? Well, we know it's at least 65 because when you go in septic shock to a mean arterial pressure of 75 or 85, no measure of flow was very different. Osvar from the French group tried to see if this was really true in a large series of patients. So they had patients in which they targeted 85 or 65 to 75 as the mean arterial pressure, and they had no difference in outcome. But importantly, if you had a pre-existing hypertension and you were in the low blood pressure group, the Australians are right. You'll go into renal failure and you'll need more renal replacement therapy. But if you were not previously hypertensive, you didn't need to be in the high blood pressure group. Why don't we make everyone 80? Because the complication rates in terms of cardiovascular effects of giving vasopressors is real. So if you don't need to give them, you shouldn't. So at the end of the day, you want to find that spot on the vascular waterfall which is appropriate for your patient based on their prior cardiovascular state, hypertension, and response to fluids. So let me just summarize to give it to you in a perspective. You want to get a perfusion pressure to be above the autoregulation level. Perfusion pressure is the primary determinant of organ blood flow above that autoregulatory range. I'm sorry, below that autoregulatory range. Above it, autoregulation occurs. Perfusion pressure is not mean arterial pressure. If you have intra-abdominal hypertension, a mean arterial pressure of 70 may be a perfusion pressure of 30. You don't know. You have to measure the back pressures. So measure the back pressure. If you're treating neurologic patients, everyone knows to measure intracranial pressure. Measure intra-abdominal pressure. All you have to do is hold the Foley catheter up and see the height of the fluid. That'll tell you the intra-abdominal pressure. You don't have to do anything fancy. It's really simple. And remember that in various disease stages, such as left ventricular hypertrophy, vascular diseases, and sepsis, the autoregulation is blunted, and therefore targeting mean arterial pressure and organ perfusion pressure as specific goals in resuscitation makes sense. But then you must look at end organ function, in the case of the kidney urine output, to see if in fact it is improving. And finally, what you want to do, what do? I target initially a mean arterial pressure of 65, and then I look at the patient. If they're peeing, conscious, lactate's going down, everyone's fine, I'm happy. But if they're not, then we go up and we measure the back pressure until we identify a perfusion pressure which is adequate. And with that, I thank you for your attention.